Welcome to the Metabolic Link, a podcast that explores the common thread of metabolism in health and disease. This is where science meets society. Welcome back to another episode of the Metabolic Link. I'm your host, Dom D'Agostino, and today we are interviewing Nicole Laurent. Nicole and I had a great conversation recently in Miami at the Metabolic Psychiatry retreat. And it was really fantastic to catch up with her there and on this podcast. So Nicole is a licensed mental health counselor in Washington State. She graduated from Argosy University with a master's in clinical psychology in 2007 and has provided psychotherapy for over 15 years in her practice. She completed postgraduate training in nutrition and also in integrative health from Maryland University of Integrative Health. Nicole assists patients with the ketogenic diet and also other metabolic therapies specifically for mental illness and neurological disorders as an adjunct to psychotherapy. And she also works to educate the public through education outreach regarding ketogenic diets with her blog, which is mentalhealthketo.com. She's also very prolific on social media, especially on Twitter. And she's done a number of podcasts that I listened to prior to doing this one with her. And she also develops online programs to increase public accessibility to metabolic and nutritional therapies. So please watch and listen. Enjoy this podcast with Nicole Laurent. Thank you. Great. Nicole, thanks so much for agreeing to do this interview. I'm so excited to talk to you today. And I think we have so much ground to cover. And I sent you just a few topics off the top of my head, but there are so many things beyond, which just on top of my head, based upon our discussion that we had recently in Miami and the amazing work that you're doing, not only with patients, but also really spearheading and putting a lot of information out there in what I would call education outreach. Mm-hmm. So maybe I'll just like to revisit the conversation that we had over dinner, and you were telling me a little bit about what you were doing and your path to that. And it was also really exciting to see that you got a Metabolic Mind award. Yeah. So maybe you could tell some of our listeners sort of your path to this journey that you're on and helping patients and how that led to the award and everything that you're doing.
Yeah, it all kind of unfolded. So I, in graduate school, I developed a chronic pain syndrome called trigeminal neuralgia, which is a lot of face sensitivity and pain. And I ended up getting daily migraines and did all the physical therapy and tried to do all the things they told me to do. And then ultimately I had a doctor tell me you're just going to have to go on pain pills because we don't have another treatment for this. So I remember like crying in the office, just kind of being sort of terrified because I just really wanted to just feel better. And that kind of pain is very grating over time. Every day to have a migraine or to have face sensitivity, the wind blowing on your face, causing really a lot of pain was a lot. And I was trying to get through my graduate program in clinical psychology. It happened my first semester into graduate school. So I went on the pain medication and I eventually had to figure out how to treat my own condition. So
would you mind telling, what pain medication you were on and also what, if you don't mind, I have a real high interest in pain because I actually think ketogenic therapies and ketones may help with pain for different reasons. But maybe if you could give a little insight, just because I'm very interested in what triggered the trigeminal neuralgia and also what pain medications like Neurontin or whatever they put you on.
Oh my gosh, they had me on all the cocktails over time. So I was suffering with this pain condition probably over 10 years. 10 years stuck on the pain medication. So they had me on everything. They had me on, they had me on gabapentin. They had me on hydrocodone at first. And apparently I am one of those people who habituate to it very, very quickly. So
everybody does. Yeah. Gabapentin, there's Yeah, it stops working really fast, and you have to escalate the dosage
Yeah.
and opioids, and especially gabapentin, surprisingly. Yeah.
Yeah,
Or
I didn't. Well,
Neurontin.
I
Yeah.
didn't.
Hmm.
Yeah, I
Yep.
didn't know anything about them, so eventually I was on this ginormous dose of morphine. Like I'm a pretty small human, and I was on a huge dose of morphine, and they're like, "We just can't take you up anymore," and I still had pain. So I was very motivated, and I came across information on a neurostimulator
Mhm.
operation. Saved up for that for a couple years because it was quite expensive. This was during the time when if you had a pre-existing condition, you couldn't get insurance, right? So I
Yeah.
had to work towards that. Got the neurostimulator. That worked. Thank goodness. It was wonderful. And then I was still stuck on the pain medication without the pain. And my doctors had a terrible time getting me off of it. They would try to do bridge medications on me and they wouldn't take. I would be okay for a while. And then I would end up in the emergency room thinking I was ill, really ill. And they would be like, oh no, your bridge medication didn't take. We have to
Yeah.
get you back up to your old dose, stuff like that. My liver enzymes would go through the roof. They had to give me the bridge medication that they give pregnant ladies so that because there's Suboxone and Subutex. And if I remember right, I had to have Subutex for whatever reason. And then I was stuck on that bridge medication. They couldn't get me off the bridge medication. And for anybody listening on bridge medications, those are not a panacea. Those are not fun. So my life looked
Any pain medication,
any pain
really. I mean, I guess
medication.
people may
Yeah.
consider some pain medication fun, just because the euphoric effects that you get from some of them, and then that can trigger. I mean, because I get a lot of emails about people in pain, so this conversation is extremely important. And pain medication and getting off pain medication can lead to depression and anxiety, benzodiazepine withdrawal, things like that.
Yeah.
So this conversation is, I don't think we've never covered it, but I think it's a super important conversation to cover. And wait, maybe you mentioned it, but what triggered the neuralgic?
I think it
Was it a
was
sudden onset?
reading. I think it felt like a sudden onset. I have hypermobility syndrome, that form. So I think I was really excited about my program. I was reading for really a lot, like your head down, like there wasn't the computer, and not everything was on computers back then. That's how old I am. But it was the head down and just 4 to 6 hours of just absorbing information. I think it triggered something that I couldn't calm down, even though I tried a lot of different things.
I'm going to ask some questions like, do you, because I've had people reach out to me with similar kinds of pain where there may be like a viral etiology, whether it be like CMV, Epstein-Barr, C19, not going to say that, but like other things, or an infectious disease process, for example, like Lyme's disease, which seems to be a root cause for some neurological pain, even Alzheimer's disease and things like that. So were you able to rule out any potential infectious disease, potentially a virus causing, or like dental work or things like that, that could have triggered that? Just curious.
I did not. I was just in standard conventional medical care. Nobody was testing for that kind of thing for that back then. But I've always been kind of, until I did the ketogenic diet, I've always been someone who's been struggled with fatigue, was very tired. Like when I was 18, I actually went on disability for chronic fatigue syndrome for 2 years out of the blue. So I could have had a resurgence of, Epstein-Barr, CMV, or something like that happened under the stress of graduate school. That would not surprise me at all. But yeah, so that's another reason why I always thought, well, I'm just not someone with a lot of energy, or I'm just not someone who's going to be athletic, or I'm just not someone who can do these things, or I have to pace myself, but really that wasn't true at all. I just didn't have the right fuel. I didn't have the right things that I needed. Nutrition.
Well, the ketogenic path that you went on has been very efficacious for many people who have contacted me with Epstein-Barr, CMV, HSV, a couple with HIV, even COVID-19 and Lyme's disease. There's actually quite a few people with Lyme's disease. It's worked remarkably well. So just like to add that, I mean, if there's people in there struggling with different, infectious diseases, and they may not know it, they have it, but everybody has, these viruses, and it's our immune system, and inflammation can trigger them it can trigger viral shedding and can trigger the onset of diseases. Shingles too. I've gotten quite a few people email me when they have a shingles attack, they start fasting and they start, and this controls it, and it basically nips it in the bud. They might get a couple little bumps here and there, but it has been amazing for them from that perspective. So just wanted to add that. I don't want to derail the conversation, but I was very interested in kind of the etiology of neurological pain, and then it'll give us some insight into, how ketogenic diets are working, and that, because pain can be the root cause of anxiety, depression. Pain is pathophysiologically linked to depression and brain fog and all these things. So I think there's something to unpack there.
Experienced all of that. And so, so I was stuck on the bridge medications, and my life was very kind of small and contained because I was someone who I would take the medication. It would make me kind of sleepy. And then I would go see clients for 3 hours. Then I would have to go home, because basically when you're on bridge medication and it wears off, you feel like you got the flu. You start to get the flu. You have to run back home. I would fall asleep with my cat Lola, take a nap with this bridge medication, eat some food, go back and see clients. And that was my days. And when we would go on vacation, I would have to plan it around this bridge medication. So it really was awful. It was awful. And it was a very limiting kind of quality of life. But that's where I was. I got the neurostimulator out because, again, that fixed my pain. And again, I had to advocate and find a surgeon and do all of that. The medical establishment did not offer that to me as an option. And so finally, my husband got a job here in Vancouver, Washington. We were going to move. And my prescriber was like, Nicole, I'm really worried that you're not going to find someone to prescribe this bridge medication for you. There's a gentleman who's doing an experimental protocol for detoxification. Would you like to try it? And I was like, oh my gosh, yes. So I did that. And remember, these pain medications, people don't understand that they're big hormone disruptors. And over time, my cognitive function on these medications suffered. So when I was in graduate school, I was someone who could read and then think about what I wanted to remember. And I could almost see the paragraph on the page in the book that I read it on. That was like how my brain worked. And by the end, even before the detoxification, I had a couple come into my office who I had met a month prior because I was going to see their adolescent, and I didn't remember their face. And I had trouble, you run the credit cards for the copays. I had trouble holding more than 1 or 2 numbers in my head at a time to punch it in. And so there was a huge discrepancy between where I started and where I was. And then I did the detoxification protocol, which was awful. And I was sure I was dying when it was happening. But when I got done with that, I was in really bad shape with my cognitive function. And when I look back now, and I think about how I was functioning after the detox protocol, even 3 months after the detox protocol, it was brutal. I had trouble getting up to go to the bathroom after that detox protocol. So, and my daughter was making my food for me. Like it was really a bad time, because not just during the detox protocol, but also, and I don't really talk about this too much, but, for all those years that I was on those medications, it affects you. It affects you. Like, I probably missed out on a lot of opportunities for fun stuff with my kids, right? Because they make you a little tired. They make you a little blah. They make you a little unmotivated. And so it really affected, I think, when I look at my energy now and my ability to be present now and my ability to do all the things now, I think, oh my gosh, I was a shadow of the mom I could have been. Right.
Mm-hmm.
And so that, I mean, we talk about these things like, oh, they're hard to get off of, and, you know, people need other options, but there's collateral damage to just offering prescriptions. There's collateral damage to not offering alternative treatments that have a good evidence base in offering those to people. Like
Absolutely.
That was the easiest thing, was for the doctor to say, here, you're just going to have to take these pain meds. You're in terrible pain and we've got to fix that. And we're just going to have to manage this condition. But there was a operation that I could have been offered. There was, you know, and my doctor didn't know about a ketogenic diet, I'm pretty darn sure. But I mean, it would have been great to have that. That might have been a game changer for me.
Yeah.
So I got off these medications. My brain was in even worse shape. I had trouble reading, and which was a big change from graduate school, right? And so then I was listening to podcasts, and I heard you on STEM Talk, talking about early Alzheimer's kind of research that was going on. You were talking about the cool stuff you were doing with the divers, and that piqued my interest. And then I just kept listening to podcasts until I finally figured out how to do a ketogenic diet. And my brain just turned back on. And it wasn't like I just suddenly, like I am now, able to find words and stuff but the energy kind of came on, the lights came on, and I knew I was on the right track.
What was your diet like prior to learning about the ketogenic diet? And also, like, what was your lifestyle like? Were you exercising? Were you, was that part of your daily routine? Were you getting outside? Were you paying attention to nutrition and exercise prior to kind of going down this path?
Yeah. So I was seeing a very excellent functional medicine practitioner all through that period of chronic pain, and while on the pain meds, and taking, you know, hundreds of dollars of supplements a month, trying to, and it was a whole foods diet. And so no gluten, like I was taking really good care of myself. I believe I was still eating a little bit of sugar, but very, very low sugar. So that was the thing, that didn't do the trick for me. That was not enough for what was going on with me. And it wasn't until I found those kind of ketogenic macros and started making ketones that I did so much better. And no, I wasn't working out. The thing about, so I love that there are so many different ways to improve mitochondrial function. But I have to say, when your frontal lobe is not working well, asking someone to get up and exercise, well, that makes sense. And yes, you can take them for a walk, and you can take them for a run, and you can try to get them moving. But that goal-directed behavior is really hard when your brain is not working. And we see that in neurodegenerative diseases, right? The urge to get up and move is not there. The energy is not there. And if you don't have good brain energy, you don't have good body energy. They are connected. So a lot of things kind of cleared up within the first kind of 3 months of my ketogenic diet. So my brain turned back on. I felt so much better. I noticed a huge change in my mood, and I never considered myself kind of anxious or overwhelmed. But if you think about it, if your brain energy is really low, everything's kind of overwhelming, right? So that went away. And I had plantar fasciitis pretty bad when I did the ketogenic diet. Didn't go to, I'd go for an hour to Costco, and I'd be on the couch elevating my foot for the rest of the day. And that went away after 3 months. And in 3 months after the ketogenic diet, after I got my macros right, I joined a gym, and I was doing body pump classes. And I was a couch potato before, an absolute couch potato.
Were you weight stable? Like, were you always small and lean like this? Or I mean, because sometimes, as people lose weight, all the metabolic biomarkers improve. And then conversely, I mean, I've seen people start a keto, nothing changes. They're eating perfect. For example, they have epilepsy, and the diet is kind of like, as you described before, but it was really that process of getting the keto macros, getting ketones elevated, and the therapeutic state of ketosis, which was the real trigger in helping them. I mean, this happens, in epilepsy, and it's, being in a state, following the ketogenic diet as it's prescribed. seems to be, the big
Makes a
factor.
difference.
Mm-hmm.
Yeah. So I have almost always been weight stable. My second pregnancy, I gained quite a bit of weight out of the blue. There was some metabolic issues going on there. I don't know what they were. Didn't have diabetes or anything, but I gained a lot of weight for me. And then, of course, when you are on opioids, my appetite went down on the opioids. And so I got pretty thin. And then after the detox, I had trouble eating for a long time. So I was underweight when I started my ketogenic diet. And I actually gained weight on my ketogenic diet, probably going up to a healthy weight. And then I built lots of muscle there for a while when I was working out really regularly. So it was really good for me that way.
Mm-hmm. So this then influenced your path to incorporating the ketogenic diet in what you do, being a ketogenic coach and a licensed medical health, clinician or practitioner in that field. So I guess, maybe describe that a little bit, and then advice, because I get quite a few questions from students who really don't know exactly what they want to do. And they're kind of like in the middle of their academic career, and emails, and also just students that I talk to, and maybe some advice on how they can steer their careers, because we need more people like you and we need more people kind of in the trenches helping to be that interface too between the prescriber, who may not at this time understand everything that you understand and the science behind it, and just they don't have the time to learn about it, but they need sort of and the prescribers also need, and that's another conversation too, how you work with prescribers when you're dealing with a patient.
Yeah. So, I sit across from patients all the time. I'm a licensed mental health counselor, and I do psychotherapy, and I do lots of great psychotherapies, DBT, CBT, EMDR. And so I get all kinds of people with all kinds of varying levels of illness going on, mental illness. And so I would sit across from them, and I knew the profound kind of mood shift that I experienced on a ketogenic diet. I noticed my brain worked better. My memory was better. And here I am asking them to do, these types of therapies are hard, like cognitive behavioral therapy. You have to identify what the automatic thought is that is feeding into a negative emotional pattern for you. I mean, that's a big cognitive load, the awareness of trying to sit there and be like, oh, what was I thinking right before this or that? And there's worksheets. And, I'm sitting here asking these people to do this, and their brains are not working well. And their mood, they're very overwhelmed by the process of therapy. And I'm thinking, oh my goodness, you would benefit from this, but I cannot talk to you about it, So I would start with like, hey, you should you listen to this podcast with Dom, right? You should check out these people talking about this. And some of them would take to it and some of them would not. I have a lot of people in my office with mood disorders where the underlying cause, quite frankly, is diabetes. They've got a metabolic issue that is affecting their mood and their functioning, and they've got cognitive symptoms, and sending them to me for psychotherapy for that, while I can be supportive and helpful, I don't think is the appropriate treatment, right? They're on, So anyways, I got really uncomfortable watching people suffer needlessly in front of me. And the few people that I kind of steered towards a ketogenic diet, they just did beautifully. And they worked with their psychotherapy in a much different way. So we got much farther, and they got so much more out of it with just a slightly better working brain. And really, this was the promise of medication. So when I was in graduate school and I was getting my training at my practicums, it was, the first, and it's even on our licensing exams, or our testing that we get to get our license. They talk about you have to answer the question where first medication, then therapy. Oh, is this going on? It's not therapy first, it's medication and then therapy. That's the magical combo, is what they told us, is that you send someone for medication and their brain improves a little bit better, and then they're going to do better in therapy. That's what all the research showed. But that is not what I experienced as a licensed mental health counselor. What I
Mhm.
experienced is they go for medication, they come back suddenly okay with whatever was going on in their life that was not working well for them. Nothing gets resolved. Their motivation for doing psychotherapy goes down because they're feeling more level, but also we're not addressing any of the things. And sometimes I would get people in my office, quite frankly, that were so over medicated, they would fall asleep in my sessions. Like I
Mhm.
have a memory of an adolescent that did that. I couldn't carry on a conversation. So the promise of that did not pan out. But when I would do a ketogenic diet with someone and then psychotherapy, it was amazing. That was what I was looking forward to.
So the
That
brains were
that
more
was
receptive to it.
yeah,
Yeah,
they're
for
not
sure. Mhm.
overwhelmed. They do their
Yeah.
homework. They're able to access and reason in different ways. They have the motivation to do it. It just makes all the difference. So I really enjoyed putting those two together. And it started, I had a client that I still see who does not want to do the ketogenic diet. She tells me that sounds awful. She's not going to do it. She has anxiety. I've seen her for a long time. But she said to me, she said, do you even have any nutrition training to be talking to me about this? And I was like, I don't. You're right. So I went back to school and I got a postgraduate certificate in nutrition and integrative health. And then I just started taking all the trainings I could. Nutrition Network has a great one on
Yeah.
neurology. I took some certifications for therapists about nutrition, which didn't talk about the ketogenic diet, actually gave misinformation about the ketogenic diet, which was horrible. But there's stuff out there that therapists can get so that they can talk about this stuff without being concerned for their license.
Mhm. What resources, because I know I'm going to get this question from people that I know and maybe, people that are emailing me. What resources did you find were most helpful in navigating this path and getting the most important information in regards to the implementation and the use of the ketogenic diet outside of its standard of care, which would be kind of epilepsy and neurometabolic disorders, so
Mm-hmm.
which some of them we study in our lab. uh, where did you find the most helpful information and the certifications that
Yeah.
really helped you in helping patients?
So I didn't learn a ton of great things from Maryland University of Integrative Health, even though they're a very well respected
I was going to ask about
college.
that.
Um,
Yeah, they are. Uh-huh.
yeah, there and so there wasn't enough there's nothing about metabolic psychiatry or metabolic
Yeah,
interventions or
not
anything
yet.
like that.
Mhm.
So that was a lot of associational studies and stuff like that. Um, I didn't, there's a certified mental health integrative practitioner, one from Evergreen, that did not have enough information. So there's really a distinction. I think that for the mental health counselors and the psychiatrists who really want to help with this, they have to understand the difference between nutritional psychiatry and metabolic psychiatry. They're
Mhm.
interrelated, but they're different ball games. And so you can go and get some training in nutritional psychiatry. You can learn that there's a connection between
Yeah.
gluten and depression, and what kinds of vitamins and minerals and fish oil and all that good stuff. And that's all really important and useful. But for actual working with people with serious mental illness or treatment resistant types of conditions, understanding a ketogenic diet and metabolic psychiatry, I think is really where you want to put your training. So I loved Georgia Eads training,
Mhm.
diagnosisdiet.com. You can find that. That was well worth it. And for any prescribers listening, that offers continuing medical education credit. So there's no reason to not go and get that training there. She's wonderful.
Yeah.
And then advanced ketogenic therapies. They have a beginner course and an advanced ketogenic therapy course that talks about using it with different diagnoses. They're
Mhm.
also excellent. The two instructors there have been doing it for over 30 years. So there are really great places to get very useful nuts and bolts education about how to help people with this.
Okay, great. Yeah, that's super helpful. And I mean, that's the key. I think we need more CME credits and more of a virtual platform and just more instruction and more content in this area to attract, clinicians and prescribers to be able to acknowledge this and steer their patient on a path to deprescribing, and that could be kind of tricky in that, their toolbox is a toolbox of drugs. And but even with epilepsy, the brain is much more receptive to pharmacotherapy in the context of a ketogenic diet. The drug Keppra, I remember being invited to and then flying out to Europe to meet with, the pharmaceutical company, along with a lot of people who are epilepsy experts. They were just trying to understand. It's more of like a fishing expedition to understand how and why the ketogenic diet enhances the brain's responsiveness to particular anti-epileptic drugs, and maybe with the intent to sort of make a druggable form of the ketogenic diet, which is an ongoing effort, and, in different, just to understand how ketones work. And that's a kind of an interesting, discussion there, because there's questions as to when you put someone on a ketogenic diet, insulin goes down, glucose variability is stabilized, ketone levels go up. And in your patients, do you ask them to, and I know it's a pretty big ask, to basically, if they implement a ketogenic diet, to measure ketones, to measure glucose, and do you see any correlation with their ability to achieve and sustain ketosis and the outcomes that you're looking at?
I do. So it depends on what they're coming to me for. So again, I take insurance in Washington State, and so I get a whole variety of people willing to do different levels of different things. So for example, I have a binge eating person who has a history of low-fat diets and tracking constantly and having a lot of stress with that. With her, we don't check her ketones, but she's doing fantastic. And it's really fixed that binge eating disorder for her. She's doing great, and she's not testing ketones. The people that I do bipolar disorder with, for example, I do ask that they test their ketones because it helps me fine-tune stuff. Everybody is just a little bit different. So I do like that. And I think it's a really important behavioral feedback, because if they can be like, oh, I feel really good, my brain feels really good, I'm going to test, and they get kind of an idea of what that level is, or, oh, my brain does not feel good, let me test, and they see that there's something going on there. That's a behavioral feedback loop. And if we want them to be able to stay on this diet in order to treat a condition, that's data that they need. So I recommend testing.
And it's empowering to them too, to really show that they could change their metabolism in a way that's really altering the fuel that their brain is using. And I think if you, as I'm sure you do, coach them into understanding that ketones are an alternative energy, and your brain is starting to use not only glucose, but also ketones, and more glucose is not better for the brain. There is a glucose hypometabolism, but similarly, more ketones may not be better too. And I get lots of people trying to jack up their ketones to, 3, 4, 5 millimolar with exogenous ketones. And some of the research that we do, quite frankly, and I was a pretty enthusiastic person about getting ketones up high, but much like glucose, like you wouldn't be chasing high numbers of glucose to deliver. And if you have, basically what happens is energy toxicity. And I mean, we've seen it in our animal models. When their ketones get high, they get sick, right? And the sweet spot for general, like, it seems like behavioral, enhancing aspects of behavior, anxiolytic effects and anti-seizure effects, and other even anti-cancer effects, the once higher is not better. And right around like the 1 to 2 millimolar range is actually pretty good, unless we study something called central nervous system oxygen toxicity, which is a very powerful tonic-clonic seizure. And in that case, a 3 to 4 millimolar elevation of ketones is going to be really kind of what we want for that acute, high dose.
Protective.
But generally speaking, I think, and myself included, I think, and I used to tinker a lot with ketone esters, and I just don't feel, if I take a large dose of a ketone ester, within about 2 or 3 hours later, I'll get a headache. And what happens is that the high dose of ketones will shut down your endogenous production of ketones. And we don't, because, and it's, for me, it's about if there's a delta of 2 millimolar of ketones, which is really hard to get with a ketone salt, the electrolyte salts, which actually give your body electrolytes, which are important, very important with a ketogenic diet.
Right.
That does not happen. And I've measured insulin in response to the ketone salt administration. But like, high dose of 1,3-butanediol or a ketone ester, the ester that we work with, and then the monoester, these things actually will increase insulin. And what happens is you get a very rapid high elevation of ketones, which you kind of feel great during that. But then as the ketone levels drop, you become hypoketotic and hypoglycemic because you'll be releasing insulin. It'll facilitate glucose disposal. Also, the ketones seem to decrease hepatic glucose output. So about 2 or 3 hours later, people, will report a headache. If they're not taking it with food and other things too, more likely to happen. So these are some of the considerations. I think we have to have an understanding that higher ketones is not better, but it's really about metabolic stability. And if you throw a big hammer into the system, you're causing shifts and alterations and counter-regulatory mechanisms, like, for example, an increase in insulin, which can then disrupt things a few hours later. Right. So I think it's really important to, stick with the ketogenic diet. Supplements are not a replacement. They can augment the ketogenic diet, but I think, you want to deliver ketones in metered amounts and then monitor your response to that, I think is an important thing that I've appreciated through all the work we've done in animal models, some of the human studies we're doing, and also just hundreds of emails that I get for patients that large doses of exogenous ketones are not the answer, and that a more nuanced approach with diet first and foremost, and then we use exogenous ketones, much like MCT. I mean, the MCT-based ketogenic has been around forever, and we know that you talk to the registered dietitians, you talk to the clinicians, you incorporate MCT into the diet, and you get better ketone levels and then better seizure control. So exogenous ketones are just one of the tools, in the toolbox to help with that.
Yeah. I remember when I was trying to figure out the ketogenic diet, before I started it, I just tried some MCT oil and I did not get the same effect that I got when I did the ketogenic diet. And now I use MCT oil and I use a little bit of BHB salts almost every day. It just makes my brain feel a little bit better. I think it's just a little bit of extra energy. Yeah.
The combination of exogenous ketones and MCT, if you incorporate the exogenous ketones with the MCT will increase your endogenous production. And then the salts too. I think the electrolytes of sodium, potassium, calcium, and magnesium that are the MCTs or the BHB is bound to can be very beneficial. For example, because I've seen blood work, it usually happens in the first 2 to 3 weeks. There'll be like low sodium, low magnesium, sometimes low potassium shows up. So I think it's really important to get the extra electrolytes in, because that suppression of insulin has a natriuretic effect where you're dumping more sodium. And if you don't replace that, you're not going to, and you can get some, electrolyte issues. They're usually pretty mild and the body compensates pretty fast. But for me, like even someone like me who's been on it for a long time, I do feel like I need to get in extra salt, especially living in Florida, sweating a lot and things like that. And I think it's important.
Yeah, I sauna almost every day. And so I think the electrolytes, I think the electrolytes really help. I always talk about minerals with clients, like those are your spark plugs in your race car and you need a lot of them. Right.
Oh, yeah.
And so, they get that. And so I think it might be the electrolytes, that extra calcium and the stuff in there that actually makes me feel better. Yeah.
And the consulting that you do, Nicole, is pretty much all telemedicine, right? Yeah. Exclusively telemedicine.
Yes, this is my corner. Yeah.
Pros and cons to that. Are there, and it just seems like, for a counselor, you're not measuring their blood pressure and things like, you can instruct them to do certain things, but do you see any drawbacks to would you do anything different if you were meeting the patient, personally, or do you see any drawbacks to the telemedicine approach that you do?
I have a functional nutrition background now a little bit. And so sometimes I wish I was with a client so that I could look at physical signs of nutrient insufficiencies and deficiencies, but mostly not. Mostly, well, I had an office and then COVID hit. And then my lease came up and I had already been working with patients this way. And I was like, gosh, I don't think I need an office and I'm doing great work and people are getting results. So no, I think that telehealth works pretty well, the consulting. And then, people find it to be very useful to be, if they come in from a meeting, they can call me from their car and we can do a check-in or, so there are some people like with young children at home who would really like to go to an office and have some privacy for that for sure. But for most people, they find it to be really convenient and helpful.
And you're licensed in Washington State, but you can consult with anybody.
I do. It's a different relationship. So the way I explain it to people is that in Washington State, I am a therapist. I'm a licensed mental health counselor, and that relationship is I am your therapist. And so that has certain ethical responsibilities and things that come with that. If you are outside of Washington State, I am a consultant and a life coach, so you can't stop being a therapist. You can't stop knowing what you know as a human and sharing it with people, but you do it in a different context. Yeah. And that's what I tell other licensed mental health counselors or people who are wanting to help people outside of their state of licensure. You can always be a consultant. You can always do life coaching. Not all relationships have to be a psychotherapy relationship, and you can still help people learn about this treatment.
Mm-hmm. Are there, because I'm sure like there's a huge need for doing what you're doing. You have an incredibly important position to help people because people really do need to be coached, but I'm sure you get a diversity of people that reach out to you for help. And I was wondering, what is your inclusion and exclusion criteria, if you want to use those terms, as we do in clinical trials?
Yeah.
And with ketogenic diet clinical trials, we learned, the hard way, it's a learning curve to set the bar pretty high when the therapy or the intervention is a ketogenic therapy. Or even like a continuous glucose monitor, because there's like a learning curve to that, because we have a clinical trial for that. So what is your inclusion sort of criteria and exclusion criteria when you are working with a patient?
Yeah. So I have an online program and I do individual consulting as well. And one of the first things I do when someone reaches out to me is I have a call with them to determine which one makes the most sense for them. So the people that I do put in my online program, they have cognitive issues, they have mood issues. It's about brain health, my online program, basically. But they have to have a certain level of technology to be able to figure out the Zoom. They need to have a level of functioning where I think they can follow a lesson and then be able to show up to Q&As to ask questions twice a week and be able to function in a Facebook group. So it's kind of, it's the same thing you do as a therapist when you're figuring out if someone's a good fit for you for outpatient or not. Yeah. And then, of course, looking at their motivation for doing it and how excited they are to do it. Most of the people that I encounter, they just want to feel better. They just want to be told how to get there and what to do and how not to flounder. Mm-hmm. Yeah, they want to feel better. And then some people, I decide that that individual consulting might be better for them. Some people, because they're already pretty far along the rails and they're like basically ketogenic and they just want to fine tune some stuff and that maybe they don't need a program that's endless should they need it, So I just, if they don't have a prescriber, that's an exclusion criteria for me. So if they do not have a cooperative prescriber, I
Yeah.
can't take them into my program, and I can't do the ketogenic diet with them, because if there is not someone to deal with potentiation effects, and we can talk about what that is, then that's potentially dangerous. Because ketogenic diets are really powerful therapies, and we have to consider them in the context of other powerful therapies that are like medications. So sometimes I will tell people, we got to find you a prescriber that's willing, that you can have a conversation with about this. And sometimes I will talk to prescribers directly. A lot of them are busy and they don't have time. And I'm not a prescriber, so I just don't have the street cred, right? To say to them, hey, you need to know about this thing. So what I do, a lot of my work is teaching patients to advocate for themselves, teaching patients that it's okay to find a different prescriber who's actually educated in this, that is not a betrayal of the patient-doctor relationship. People, there's a lot of emotional stuff that comes with starting a ketogenic diet, right? You're changing your food, there's the social stuff, and there's the prescriber relationship. And in the past, for a lot of these people, and like me, and maybe that's why I have a soft spot for it, is these people you build a relationship with them because you really want to be helped, and they are an authority figure. And it's weird when you come to the place of like, maybe they don't know what they need to know in order to help me. My cat's going to visit us. So that is that piece. So not having a prescriber is an exclusion criteria for me because it's dangerous. Yeah.
And the conversation that you have, I mean, the ultimate goal is to de-prescribe, right? So you have to have the conversation is that your brain, it will be more receptive, and potentially you may not need to use these drugs in the next, couple months to years or whatever. And how does that conversation go if you do have that conversation with the prescriber? Because in some cases, the prescriber's role is to prescribe, right? And
their algorithm is to add. Their algorithm is to add.
Exactly. Yeah. And sometimes there's relationships that the prescriber has with different pharmaceutical companies and things like that. And I kind of came from that world, working in a clinical department, where I went to many lunches and things like that through my PhD. That I'm kind of very aware of that world. So I guess my question is, maybe simply put, is do you actually have any pushback from the prescribers, or these are just situations that you learn to avoid?
Yeah. Well, the way I describe it, the way I learned it from Georgia, and the way I talk about potentiation effects, I think is really helpful. So I'll talk about what I say to my patients and what I will say on my consultees, and what I say to prescribers if I can get them on the phone to return my call. And that is, ketogenic diets improve brain health, which makes brains more sensitive to things like substances and medications. And so the prescription amount, the dosage that you're on now, at some point, that's fine now, that's helping your symptoms now, may become too high for you as your brain heals and as you're on a ketogenic diet or whatever's going on there sensitivity wise. And you might get side effects suddenly from medications that you've been on for many, many years on a ketogenic diet.
Yeah.
And so what needs to happen is your prescriber, and again, I have to be very careful. I'm not a prescriber. I'm not even supposed to talk about this stuff, right? But what your prescriber might want to do is lower the dosage of your medication for 1 to 2 days to see if there's an improvement in those symptoms that might be potentiation effects, that might be side effects from too high of a dose. And we might want to be very careful about adding medications. There are instances where that makes sense. Bipolar disorder, early days, hypomania, all that stuff. So but really we want to test for potentiation effects very carefully. And people understand that, but they don't. Here's the thing, it's why it's important to work with someone. I think if you're on psychotropic medications or anticonvulsant medications or any medications, it's important to work with someone, because as you get those side effects, you're not going to make that connection. Like a good example, I have a lovely man I work with who was on a high dose of Wellbutrin, And sure as clockwork, about 6 to 8 weeks into his ketogenic diet that he was doing really well at, he got really high suicidality out of the blue. Mm. And I'm like, we better get that, you got to go to your prescriber and get that checked. And we talked about potentiation effects. But quite frankly, when you're in that state, it's really hard to self-advocate for yourself. He came back on more medications, a higher dosage and a second medication.
Oh, wow.
And he just now finally weaned himself off. Not himself. He did not wean himself off. He worked with someone to wean himself back down, but he was like, oh my gosh, Nicole, you were right. It was, they went in the wrong direction. So when, Chris and I and Georgia and anybody else, Rachel, talk about potentiation effects and having to work with a prescriber, that's what we're talking about. You're not going to necessarily make that connection. Georgia told us to have our patients go on Google, look up the side effects for their current medications, print them out and put them on the fridge. Maybe she didn't say the fridge. That might be me. But you put them up and you watch for them. You watch for them because potentiation effects happen 3 to 6 weeks.
Prescriber's not going to be necessarily completely transparent or have the time to kind of walk you through all that. And I think the prescriber's goal should be in a perfect world, right, is to deprescribe. So less is always better. In the case, in the context of carbohydrate restriction with type 2 diabetes, what endocrinologist or doctor could argue that less insulin is better? If you have a glycemic HbA1c that is maintained at 5.6 off 10 IUs of insulin relative to 80 IUs, which is something that I've seen actually. My student now, Dr. Andrew Kutnick, was a type 1 diabetic, and when he came to the lab, I was a little hesitant to kind of advocate for him to do that. I knew, because I always would kind of like, when I gave lectures, be like, well, if you're type 1 diabetic, you wouldn't want to consider a ketogenic diet.
Right.
But then he came in and he had a couple close calls, following more of a standard diet, transitioned into a low carb ketogenic diet. It worked remarkably well for him. He's been a patient advocate. He did a TEDx talk talking about the use of a low carbohydrate restriction for type 1 diabetes, which is very controversial, but the science is really emerging that carbohydrate restriction is a really important approach for type 1 diabetes, just to reduce insulin. And actually, I get a lot of, students will reach out to me, and I also get a lot of emails from people who are on drugs like Adderall, which are amphetamines.
Yes.
And, they've got success with fasting and the ketogenic diet. And this is a very high, I teach upper level graduate students, medical students, and I've come to realize that the use of these stimulants, of these amphetamines, is quite high in these students. And I've had students say, fasting is like my Adderall, like my attention, I just narrows in. And also I've had students say, thank you for recommending that ketone supplement. This ketone supplement is now my new Adderall. I've been able to get off the dose. So I go days with it and without it, and I feel better without it, and I have more focus. So this is really important because, otherwise they think they just need it for the rest of their lives. Right. So I'm not, I think there's a time and place for using these ADHD drugs, but I do think they're very overprescribed. And I think that maybe they're more appropriate for the adult, that's farther along in life. And I know if they're used early on, like in kids, they can rewire your brain in good and bad ways. So I think we need to appreciate, but yeah, I've got quite a few emails, from students that are doing ketogenic diets, fasting, and just taking exogenous ketones. And it's this is my Adderall. Yeah. And that's really heartwarming to see that, because they don't feel that dependence on this powerful drug that they feel that they need it.
Too.
Yeah.
I've seen that too. So a lot of my patients and my people that I work with in my program, they have been able to go down off their Adderall or not potentially need it. Which that's not supposed to happen. Right.
Yeah. And if you abruptly stop Adderall, it could unmask depression too, in some cases. So I've communicated with, people and students that, they were on Adderall, they got off, and it can unmask sort of depression symptoms and things like that. So, but it's just so common. And I think, I do think it's a problem that's not talked about as much as it should be. And I don't know if it's just something in upper level academia, but I do think it's a problem. And I do think nutrition is a big part of the solution.
It is a big part of it. I think there's some really serious nutritional deficiencies going on in the general population, and their brains are not working well. And it's getting a diagnosis of ADHD when really they're just not getting the basic things their brain needs to work. Like,
that was my next question, actually.
I get
your toolbox. Like, do you look for nutritional deficiencies? Do you do blood work? Do you do, like, I've been doing the Genova testing, which is fantastic. So what's in your toolbox for assessing the nutritional deficiencies?
So I think about things in terms of the brain hypometabolism. I think about them in terms of neuroinflammation, and I think about nutrients as mitochondrial upregulators and necessary for detoxification. And so I love to put people on a good trace mineral supplement. I love to put them on a good, usually methylated B, although that's not always necessary for everyone. I like to use certain things like when I fixed my brain, I got probably 80% of the way there, but I would still have days with a lot of kind of some brain fog going on. So for me, doing a nutrigenomics analysis was really helpful because I found out I don't make choline at all. And so I added a little bit of alpha GPC, and that just turned the lights on the rest of the way. And suddenly I had that focus and more brain energy, because that's the precursor to acetylcholine, right? And so there's stuff
I've used that. Alpha GPC is pretty powerful. It gives me a headache if I take too much. It's in the product Keto Brains, which like 1 scoop is enough. I've done like 4 to 6 scoops, and it was giving me it's like overstimulation. But I learned that it's pretty powerful, and you get some symptoms of like too much acetylcholine if you use too much. But it's just it's great that there's products that are supplements out there that have drug-like effects, like alpha GPC and theanine and some other things out there.
So that was really helpful.
Is great too.
You need that choline also in order to digest fats. You need it for brain structures, right? To heal your brain. So that was really helpful. So I like a nutrigenomics analysis. That's part of my online program. I teach people how to do that part. And I don't do too much testing. I do some serum blood level testing, just very simple things. I like to run patients' blood work through a functional blood chemistry analysis software that just looks, the ranges are a little more functional instead of the normal sick ranges. Gives me some clues about what might be working well and what might not. And people really like that and find that to be very helpful. It generates a report they can bring to their practitioners. A lot of the people I work with are seeing naturopaths or functional medicine people. Not everybody is just in the conventional medical system. I get a lot of people where that hasn't worked for them, and they're trying different things, understandably. So those are the things. I mean, when I get someone who I know who is going to be overwhelmed by me picking and choosing supplements for them based on how they're presenting or any type of functional nutrition analysis, I will put them on a broad spectrum micronutrient like Hardy's Nutritionals is excellent. It's a Canadian company. And it just has a really good broad spectrum micronutrient. And I actually learned about that from Psychiatry Redefined, had a child and adolescent symposium. And one of the doctors there was talking about how she uses broad spectrum micronutrients with her ADHD population of children and adolescents. And it means less stimulant medication. Again, the brain works better when it has what it needs. And I get people, high schoolers that are like, I need you to evaluate me for ADHD. And I say, I can't possibly evaluate you for ADHD until we make sure your brain has some of the basic things it needs to function. I can't assess your functioning because you don't have the basic building blocks. You're eating a tiny amount of protein. I don't even think you have enough to make your neurotransmitters. So I always do that with them first. That's something in my toolbox.
Yep. And then sugary caffeinated drinks too. Yeah. I think it's so important that you say that to them, because you need to look at what they're doing, well, what they're not doing, but what they're doing in regards to their nutrition. And I was communicating with a friend yesterday that works in the behavioral division of a school. And there's just a lot of behavioral issues that I think are linked to nutritional deficiencies maybe, but it's it's energy toxicity in regards. So you got sugar and then a lot of caffeine. These energy drinks are kind of ubiquitous in the schools and stuff, and just sugary sodas and stuff,
which are further nutrient depleting.
Yes, absolutely.
And it's a vicious cycle
that needs to be acknowledged first. So just a couple, I know we're running up on time. I still have we'll probably have to do a part 2, but I have a couple more questions. Hormone etiology. So do you, in any cases, with women, especially going through menopause, and males going through andropause, or whatever you want to call it, do you look at thyroid? Do you look at like testosterone, estrogen, or other hormones? And also I forgot to ask, what percentage of your patients are males versus females? And do you look at hormones as a potential contributor to some of the issues that you're treating?
Yeah. So again, I have a functional background. So when I see hormone disruption, my first thought is not to supplement with hormone replacement. It's what are the estrogenics and the hormone disruptors and lifestyle factors that you're being exposed to first. Yeah. So there's a lot of environmental xenoestrogens going on. There's some foods that can really increase estrogen. So I kind of think of it as, when the body is functioning well, I think that hormone production improves really well. So I'm not a functional medicine practitioner, so I don't get all up in the hormones and the testing and that type of thing. Yeah. Now I will test thyroid, and I will look for any kind of thyroid autoimmunity stuff going on, because I do like to use iodine. The brain needs iodine, right? It's a glandular organ. And I think that is not used enough in treatment and in preventative medicine. But so I'll check for that. But I just don't think that, and this might be, I might be showing some ignorance here. I'm not sure. I'm still, how we evolve and how we see things and how we look at things. But I just don't think we went through menopause, 10,000 years ago and were debilitated by it. I don't think we had to stop everyone because we were having a hot flash. I think that we are equipped for, our adrenals to take over and to make what we need as women. And possibly with appropriate lifestyle factors, gentlemen with testosterone and women testosterone too. But I think that the hormone replacement thing, and there's also some stuff around ApoE4 and whether the hormone replacement is useful for that population. We're not testing for that. So I was reading a post by a nutrigenomics expert who had mentioned that, but couldn't really show me the research on it. So I just think it's one of those areas that I feel like HRT might be being used as a Band-Aid instead of increasing mitochondrial function and see if our organs can do what they were meant to do.
My thoughts exactly.
Yeah. Oh, really? Yeah.
I have kids. I'm going to call them kids. I have kids in their 20s, in their 30s, and that are jumping on HRT, just like a low dose HRT. They have no idea. They're listening to all these podcasts talking about all the benefits of HRT.
Yeah.
And these kids are like in their 20s and 30s, which if you legitimately have a problem, many of them are suppressing it through the use of other, performance enhancing compounds and things like that, or they know how to hack their blood work to show that they're testosterone deficient. And the clinics are very quick to write a prescription and to profit off these kids. And then they're kind of hooked, on it. And I think it's a dangerous path. conversely, though, if you really need it, testosterone and other hormone, like a hormone balance is intimately linked to mitochondrial function.
Yes.
So if you are low levels of hormone, that if you restore hormones, then that could really augment mitochondrial function. So I think that's important. But you may not need testosterone. It's like, I've used DHEA in like a small dose and see that, that seems to balance. And I've done a lot of hormone testing to see that it gets me into the optimal range instead of low normal. Then it gets me into mid to high normal. But, it's like something that you can get off Amazon or something like that.
Yeah.
But, and I'm also, approaching 50 or whatever. But I think that, I think the HRT discussion is a discussion that it's too much of the discussion, really. And I think the appreciation that you have for lifestyle factors needs to be first and foremost addressed 100% before there's any movement to an HRT protocol.
Well, and I think that, so like when I was developing my online program and I was looking for brain fog populations and doing research, I would go, there's a Facebook site, a Facebook group, and it was about brain fog for women. And I thought, I should be in this group and participate in this. And what it was these women who were on HRT for brain fog and only HRT for brain fog. And it just kind of broke my heart because I would see these posts. They're like, it's not getting better. I feel terrible. I still feel awful. I still have brain fog. And I'm thinking, this is doing these women such a disservice because it is much more likely that they have brain hypometabolism going on in middle age and that they need an alternative fuel source for the brain. And just throwing these hormones at them is not doing the trick. And you could see it was almost like, am I doing it wrong? I must be doing it wrong. I must need to wait another 3 or 4 or 5 or 6 months to let this hormone therapy work. And I'm thinking that is months that your brain is starving for energy. And that is months that we are allowing an additional neurodegenerative process to happen. And so I think HRT can sometimes be lazy root cause medicine. And I think we do people a disservice.
That's a good way to put it. Yeah. Well, I just have one. I wish I had more time. We hit on so many important aspects here. I'm so excited to share this once it comes out on Metabolic Link podcast. But before the last question, because I know we're coming up on time, and I appreciate your time today. So the education outreach that you're doing is really fantastic, and I think that is an equally or maybe even more important role because you're hitting so many more people than instead of just working one-on-one with them through your blog and through Twitter and just general social media. So maybe talk a little bit about that and the motivation that you have for doing that and your approach, because social media can be exhausting and actually can trigger, behavioral, negative behavioral consequences if you're too addicted to it, which I think a lot of kids are just, in watching some of the nieces and nephews and things, but they seem to have it under control. But so what's your approach to doing that and putting out content, and what's your kind of future approach for education outreach?
Yeah. So when I went back to my doctor and I said, hey, I did this ketogenic diet and I feel so much better. And he's like, oh, an anti-inflammatory diet. And I'm thinking, you knew about an anti-inflammatory diet? You didn't offer it to me. I don't think he knew what a ketogenic diet was. But I think that, when we go through a transformation like this, I think that anger happens. We're like, why wasn't this offered? Like that was years of really difficult health. And I know I'm not the only one that feels that way. You hear it all the time from people. Like, why wasn't this offered to me? Why wasn't this given as an option?
With epilepsy. Jim Abrams, the Charlie Foundation, that's how it got started. He was just so upset. It was not offered to him as an option.
Yeah, exactly. And so I just feel compelled. I don't know the right word, but I feel compelled that people get to know all the ways they can feel better. And there is so much good science and so much experience around this, and it should be offered. And so I just really want people to know that. And I want them to understand that there is a scientific literature supporting a lot of the underlying mechanisms by which we believe this is working. And so I always, I try to be positive on my social media because I think that it's really easy to get stuck in that anger place of, the system's screwed and corrupt, and big pharma's on, going to do all these things, and it's going to keep this from people, and people aren't going to. And I don't think that's what's happening. I think that because people feel a moral obligation to talk about how much better they got after using a ketogenic diet, I think that these stories are going to continue to go out. I think people are going to continue to learn about all these ways. I think the system is absolutely going to change. And so I like to focus on that part. I like to say, hey, here's the science, and here's all the cool convergence of research and clinicians and super smart people that are working really hard to help you know all the ways you can feel better. And that's exciting. So I try to do it from that place.
I love the positivity approach because there's so much negativity online, and that's what turns a lot of people off. I mean, it's pretty easy to be negative. I mean, you can criticize anything, right? I mean, there's big pharma and big food, big sugar. I heard someone use big keto, like the keto market is. But yeah, it's so easy to be negative. So I really appreciate that you're putting positive information out there. And how can people find you on, I mean, just Google your name. I'm sure your website comes up, but maybe mention your social handles and your website and how people can best find you.
Well, I'm most active on Twitter lately. I've found that if you try to make content for multiple platforms, you just burn out really bad. So right now I'm focused on Twitter. I'm at Keto Counselor there. And my website, mentalhealthketo.com. There's lots of good resources on that. You can email me at nicole@mentalhealthketo.com. And you can also learn more about my online program and stuff all on that website.
Great. Well, thank you, Nicole. Thank you for giving up your time for this today and for doing this educational outreach for the Metabolic Link podcast. We might have to do a part 2.
That's fine.
Thank you again for doing what you do and for spearheading and being a major cog in the wheel that's growing in metabolic psychiatry. And we have to really thank the Jen and David Bezucki and the Bezucki Brain Research Foundation for, creating a path to grow this movement. And you're intimately linked into that path and doing so much work on that front. So thank you again for doing what you're doing and being on this podcast.
Thank you for being on podcasts that I could listen to and save my brain with so many years ago. I appreciate it.
Thanks for tuning in to this episode of The Metabolic Link. If you've enjoyed this podcast, please share it with others, leave a comment, leave a review, and also follow us on social media at Metabolic Health Summit. We look forward to seeing you next time. Thank you.